Good morning, everyone. I want to start by thanking the organizers. This is my first opportunity to visit India, and I have to say I have been really impressed and inspired by what I've heard and the people I've talked to. There's so much fantastic work happening in the longevity space here, all the way from basic science through to clinical application. I'm just really I think impressed, and I think you'll see based on the panel discussion this morning through to what I'm going to talk about now, some really clear alignment on mission and vision. And so the other thing I've been feeling is this excitement about the opportunity to work together with like-minded people to really hopefully usher in Medicine 4.0 globally. And so probably a good place to start. We heard some thoughts on what is Medicine 4.0 in the panel discussion. And so I thought maybe I could tell you the way I think about Medicine 4.0. And so this is a friend of mine, Peter Attia. Probably many of you are familiar with his podcast or his book. Peter, I think, has been a real leader in this concept of Medicine 3.0. And so I thought I would start by sort of talking about how I perceive the way Peter thinks about Medicine 3.0. So Medicine 2.0 is kind of still where we are. That's traditional medicine. It's mostly reactive. It's mostly individual disease focused, typically wait until people are sick and then try to do something about it. Medicine 3.0 is a shift towards proactive, preventative medicine, and I think obviously lifestyle is an important component of that, but it's also about not waiting until people are sick. It's about detecting disease early, and when it's detected, taking action to mitigate that and hopefully reverse disease and bring people back towards the healthier state. What is Medicine 4.0? And so I think the way I think about this, and that's kind of what I'm going to talk about throughout the rest of my talk, is it's maybe where we need to get to, because Medicine 3.0, as we heard in the panel discussion, I think will be and will continue to be challenging to implement on its own, and I would say maybe isn't going to be sufficient to achieve the goal. So that's kind of one of the take-home messages. So first of all, let's start. Why doesn't Medicine 2.0 work? I think one of the reasons, well, let me say, it works really well in some cases. I think we have done a really good job of keeping sick people alive, particularly in the United States. What we haven't done a good job of is keeping people healthy. And one of the reasons for that is it's reactive, I already said that, and it thinks about diseases in isolation, right? Typically we wait until somebody develops cancer or heart disease or kidney disease, and then we try to treat that disease in isolation. Brian talked about this in his talk. What is not recognized is sort of the connection between all of these diseases, which I would argue is the biology of aging. And just to give you some statistics, this is all going to be from the United States. I know it's going to be a little bit different in India. I would say maybe this is where India is heading if we aren't successful, and we will be, but if we aren't successful at bringing in a new type of medicine. So in the United States, like in many countries around the world, life expectancy went up dramatically over the last 50 to 75 years. It has started to plateau, and nobody really knows if that's going to get to a downward trend, flatten out, or start coming back up again. But it seems as though life expectancy really has started to plateau in the United States. In 2024, life expectancy, depending on the exact organization you're looking at numbers from, is around 78 years. The median age is 38.8 years. And a statistic that I am constantly struck by, even though I know this number every time I see it, is according to the CDC, 60% of Americans have at least one chronic disease, which if you actually think about that math, tells us that many, many, many people are living 3 or more decades with chronic disease in the United States. And so there's this concept of sick span, which I would define as the period of life living with at least one significant chronic disease or disability, which makes up a huge chunk of the survival curve. I think healthspan is tricky, and I do want to make the point explicitly. Healthspan is not binary, meaning you don't go from having 100% health one day to having 0% health another day. It's actually something I would argue we can't measure because it's not binary, or at least nobody has really come up with a good way to measure it. But sick span, I think, is a concept that we can actually align around and say maybe we can actually measure that. So if we use that definition, it's pretty striking. The other thing that's very striking is this accounts for about 90% of healthcare expenditures in the United States today. That's a problem, and that number is going up, and I don't know when the system breaks, but I'm pretty sure that number cannot get to 100%. So something has to change, or we're going to be in a lot of trouble in the US and our healthcare system. Many people would argue we already are. Okay, so that's sort of the state today. The goal of Medicine 3.0, of course, is to really push that six-span period out, compress it down, get it much closer to the survival curve, and limit the period of life spent in poor health. And, you know, I think, first of all, it's worth saying, Medicine 3.0 has to include Medicine 2.0. People are still going to get sick. They're still going to need the hospital system. They're still going to need that care. I think we can take some of the burden off of that system by keeping people healthier longer. And then on top of Medicine 2.0, I think the sort of cornerstones here are proactive screening, personalized biomarkers, early medical intervention, lifestyle modifications, of course, that's going to keep coming up. And unfortunately today, I would say, Medicine 3.0 is also a lot about questionable supplements, experimental therapies that haven't been validated, a lot of people trying a lot of stuff in a not very scientific way. I think so that's one of the things that we need to work on. I would also say there's a lot of really uneven care right now, at least that's my perception in the sort of Medicine 3.0 world. There are some really good docs leaning in, getting informed, doing the best they can with the tools that they've got. There are also a lot of people that were calling themselves something different 3, 4, 5 years ago who have just sort of co-opted the term longevity, and they know nothing about longevity, and they're really not interested in becoming educated, or at least that's the way it seems sometimes. So there's a really uneven, I think, landscape out there that makes it very hard for patients and consumers to know how to get good care in this space. And that's sort of all under this umbrella of longevity medicine. I would also say, even if we can do all of this well, it's probably insufficient to achieve this goal. And so I think a couple of things need to be added to Medicine 3.0 to really give us an opportunity to achieve the goal. And at least a couple of those things, and this is some of what I'm going to talk about today, are, first of all, we've got to be more rigorous in the way we use supplements and medications, and we have to figure out ways to collect data that's going to allow us to be more rigorous. I think there has to be a geroscience component, and I think people like Peter Attia who think about Medicine 3.0 talk about geroscience, but I haven't seen a really, I think, rational way to implement geroscience discoveries into longevity medicine. And I think AI, of course, has to play a huge role here. And these opportunities, I do believe, really are the path towards getting closer to this goal. I just want to then add, Medicine 4.0 is much more effective than Medicine 2.0. And I think people maybe get this intuitively. There are lots of ways to think about this. This is a graphic derived from some work that J.L. Shansky did several years ago now, just asking the question, what is the impact on life expectancy for a typical 50-year-old woman from sort of Medicine 2.0 approaches versus slowing aging, which I would put in the Medicine 4.0 bucket. And what I hope you can appreciate is, by curing individual diseases, which, first of all, I don't think Medicine 2.0 really is ever going to completely cure all forms of cancer, or completely cure all forms of heart disease, or completely cure all forms of dementia. I just think that's a really tough biological problem given reactive approaches. But even if it was, the impact is relatively small. Curing all forms of cancer gives a typical 50-year-old woman in the United States about 3 years of added life expectancy. It's the same thing from curing all forms of heart disease. Even if you could do both, you get about 7 years. And if we compare that to the impact of just slowing aging, which we have to be honest, we haven't done in people yet, or at least we haven't documented it, but we can do routinely in laboratory animals, you get a much larger proportional benefit. With the added value, most of those years are predicted to be spent in good health because we've slowed most or all of the functional declines and diseases of aging simultaneously. So again, Medicine 4.0, way better than Medicine 2.0 in terms of outcomes. Okay, so this is sort of what I've been working on at Optispan and my thoughts, and I'm certainly not going to suggest that, I've got it all figured out, but I just thought I'd share with you kind of the way I've been thinking about this and we've been trying to implement. So how do we create a framework for Medicine 4.0? And again, the goal here, really, at least my goal, is to optimize health span for as many people as we possibly can. Sure, we want to increase lifespan, but I think really we want to give people as many years of good quality health as we can. And I think this really incorporates some of the principles that Lee Hood first talked about, called P4 Medicine. And for those of you who aren't familiar with Lee, he's a fantastic scientist in the sort of systems biology, systems health world. He's our scientific advisor at Optispan. And so he coined this term P4 medicine, which is around medicine that is personalized, predictive, preventative, and participatory, meaning that people have to participate. I would add a fifth P to that if we're going to be successful. It's got to be pragmatic. And what I mean by that is it's got to be something we can actually implement. It's got to be affordable, and it's got to be scalable so we can get this to as many people as we possibly can. And then as I've sort of alluded to, it really better be scientifically rigorous if we're going to do a good job of actually improving people's health span. And I think this isn't something else I also don't hear talked about a lot. It's got to be medically and ethically sound. And again, given the gray areas in this field, I think it's not always clear where the line is between what's medically and ethically sound for providers when they're trying to navigate a lot of the noise here. So I'm hopeful that we at Optispan and other people here who are interested in this collectively can help get to a place where we can develop some common standards and frameworks. So our approach is really around trying to develop a platform to enable Medicine 4.0. And I think, again, there are other people who are thinking about this, and I'm really excited about the possibility of working together with like-minded people. So we want this to be a one-stop shop for best-in-class health span medicine. And I think part of that is standardization around protocols, vendors, diagnostics, the way you interpret it, the tools that you use. It's got to involve automated data flows. So we're going to bring in a lot of data about people. We have to integrate that data. We have to analyze that data in a coherent manner. And we've got to get it back to the stakeholders, right? The docs, the coaches, the clients, in a way that is useful for them and gives them the information they need without giving them too much information or without giving them bad information. Obviously, it's got to be personalized for the individual as much as we can. That's going to be a moving target, but it's going to get better with time. And as I mentioned, there are multiple stakeholders here. In our program, we have doctors, we have coaches, we have a care coordinator, and we have the client or the patient. And all of them have to get the information they need in the way that they need it. So that's what we're trying to build. If you're interested, there will be a special issue of Scientific American coming out, I don't know, sometime in the next couple of months, really around this sort of emerging field of longevity medicine or health span medicine. So I've got an article in there kind of about this concept. Lee Hood has an article in there. And Eric Verdin, the CEO of the Buck Institute, also has an article in there, along with some articles that were written by media writers. So again, in our approach, we, like I said, take a team approach, doctor, coach, care coordinator. We start, like many programs do, really trying to get a comprehensive baseline on our clients, right? So get as much information about their current health status as we possibly can. It's a lot of diagnostics. I'll give you sort of a partial list, but the reality is, more or less, it's overlapping with what a lot of other people are doing. We also have quarterly reassessments then after that comprehensive baseline evaluation. I think one thing that I am going to hammer continuously is we really have to measure. We got to measure before we intervene. I see a lot of people just start giving supplements without ever measuring anything. I don't think that's the right approach here. I think we got to figure out where people are at. Then we intervene based on that information. And then we measure again and make sure it's working. And we can iterate on that to get people onto, hopefully, continually improving health span trajectories. At least that's our framework for how we think about it. Of course, at any time you bring the general population into a program like this, a lot of people are going to come in with pre-existing pre-disease or disease. You got to fix that first. Maybe that goes back to Medicine 2.0. Maybe it's pre-disease that you can change through lifestyle or medications, but you have to take care of people where they're at, and not everybody is going to be, super fit biohacker guy that comes in. A lot of people are going to have pre-existing disease. And then we'll do a deeper dive as needed. So again, you're going to find things that require advanced diagnostics. Our focus is always starting with lifestyle. And again, people have different ways they think about this. We think about it 4 pillars: eat, move, sleep, connect. We like active words. We like to keep it as simple as we can. Eat, of course, is nutrition. Move is exercise. Sleep is sleep. Connect is the one that is, I think, probably least talked about and maybe most important for a lot of people. And that includes both your own connection to yourself. Some people would call that mindfulness, connection to the world around you, and connection to other human beings. And I think that should not be underestimated. So we spend a lot of time thinking about that. We don't have as many tests. It's not something you can go get an MRI and tell you how's your connection doing based on your MRI. So I think we need to do some work here. We focus on lifestyle first, try to figure out where's the biggest bang for the buck, which levers can we pull to get the biggest effect, and then we move on to supplements, medications on an individual basis. Again, measure, intervene, measure again. So this is some of the stuff that we use. And again, I don't want to spend a lot of time talking about specific diagnostics. I'm happy to talk with anyone here who's interested in as much detail as you want to. We obviously do comprehensive blood work. We try to look at all of the major processes, and then we're doing a little bit of discovery, trying things that aren't typically included to see what's actionable and informative, what isn't. A lot of imaging. I think point of care ultrasound, I've been surprised by how impactful that is. MRI, DEXA. DEXA is one of my favorites. That's actually my DEXA there. That's from last year. This is my best DEXA I've ever had. DEXA is great because it shows you bone density, lean mass, muscle mass, positionally, and adipose. At this point, I was actually like 11.5% body fat. I'm nowhere near that now, especially after traveling in Singapore and India and eating so much great food. But it's really powerful. So I actually think everybody should get a DEXA at least once in their 40s, at least once in their 50s, probably every year. A lot of bone density problems that you can detect early and you can take action on. So anyways, that's just one of the tools. One thing we do that's a little bit unique, at least in my experience, is we also focus on oral health. So iTero is an imaging system for the inside of the mouth that we then have a dental expert use. I don't know why, like for some crazy reason, we like separate this part of the body from the rest of the body. It makes absolutely no sense. So we really think oral health is important. But there's a bunch of stuff that you can do. A bunch of it's valuable. And we really are now, like many people, struggling to ask, how do we integrate all these data types in a meaningful way to get to personalized action plans, personalized predictions. And again, I really believe, I know it's a little bit superficial, but I do really believe that AI is going to play a really powerful role here. Okay. Some things that maybe don't work in the clinic yet. I have not been impressed with the microbiome tests that are out there. I'm not saying nobody should get a microbiome test. There are clearly people who have gut dysbiosis where you can detect specific problems. I am really not a fan of the sort of direct-to-consumer, measure everything, good microbiome, bad microbiome stuff. I don't think it's very scientific. I don't think it's actionable, so we're still really trying to figure out. I'm not saying the microbiome's not important. It really is. I just don't think we have the tools right now to do this well. So we're trying to figure that out. And then I'm going to come down even harder on the biological aging clocks. I think the direct-to-consumer biological aging clocks are completely useless, worse than useless today. Nobody should use them, in my view. They're really powerful research tools, no question about it. They're telling us about the biology of aging. They will one day get there to where we can use these in a clinical setting, but they're not there now. Look, they've got no information around precision or accuracy. Anybody in this room who considers yourself a scientist, that should be a red flag to you, right? That's a real problem. There's no quality control in the industry. There's zero regulatory validation. I'm not aware of any biological aging test that has had a regulatory body validate that test to measure anything. And I would say they're not actionable. There's nothing that a doc can do with this information that is really valid in terms of giving you a specific recommendation. And I would say, I think in the field, we've got a real challenge around, we don't even know what biological aging means. Or I think we kind of conceptually do, but we're very sloppy in the way we use that term. There's a lot of people, some of them in this room, I've done it myself, so I'm not pointing fingers, who point to epigenetic changes, which is one of the 12 hallmarks of aging. And the hallmarks of aging are an incomplete model of aging. They use that one thing, measure it, and call it biological aging, right? And then I've heard about 8 other definitions of biological aging, measuring different things. They can't all be biological aging. They can be parts of biological aging. So I think I would like to see us, and again, I'm guilty of it too, I would like to see us be more rigorous in the use of that term and being clear what we mean, because I think we confuse ourselves and we definitely confuse the general public. I would say these things are all correlated with chronological age, for sure. They're correlated sometimes with mortality. That's how some of these tests are derived. They're correlated with reduced health. All of those things are correlated with biological age. So these tests are really a correlation to a correlation of a part of biological aging. which again, I think we just need to be clear in what we're talking about. I would say for now, biological aging is really a useful concept that we don't have tools to measure. So this is my personal data that really made me think differently about the biological age test. Okay, sorry, I will go over time a little bit. You can come pull me off the stage if you want to. So I did an experiment. I did 8 different epigenetic age tests from 4 different companies, so technical replicates. These are all, in theory, the same tests. And this is the distribution of data I got back, which is really interesting and informative, and I think tells you everything you need to know. Look, if I was an influencer and I wanted to prove to people that my sort of protocol was the best, I'd just pick the Elysium data, because that looks really good. So I was 53.5 when I did this test. Elysium tells me I'm 44 or whatever. I would not pick David Sinclair's data from Tally, because it tells me I'm over 60, right? I mean, this is just absurd. And the true diagnostics is 20 years apart, the technical replicates. So look, this is all noise. Anybody who has looked at numbers and knows statistics gets that's just all noise. It also doesn't make sense. So we also have these rate of aging tests, right? Dunedin pace. And again, in the literature, I think that test is fine. I believe that it's measuring something about health. In the direct-to-consumer space, so this is longitudinal data from True Diagnostics over 2 years, for me again. This is the difference between my true age, my biological age, right, and my chronological age. And so over time, you can see between like December 22 and September 23, my true age went down. So my age, I aged at negative 15.8x, the normal rate of aging during that period. And then something really bad happened in October to November of 23, and I aged at 140 times the normal rate of aging, right? And then I was at a more sedate 3.8x, which, okay, whatever, maybe. Except there's this Dunedin pace, which is supposed to be the slope here, right? Your rate of aging, and it was always below 1. So I was always doing good in my rate of aging, yet my actual age was all over the place. This is all just, again, to hopefully hammer the point. I don't think there's anything useful here. Okay, so I also think there's a bunch of gray area, right? And this is where we're really trying to figure out how do we navigate it. Supplements, experimental interventions. I'm not gonna go through all this because I know I'm over time. Happy to talk about it because I have thoughts, as you can imagine, on all of this stuff. And then there's the stuff that I would put solidly in the don't mess with it right now area. Gene therapy, just don't do it, right? And I would also say there's a bunch of people out there who self-source this stuff. They buy, like for pharmaceutical use only drugs and hormones. Don't do that either. Get a doc to help you navigate this stuff would be my advice. Even if you think you're really smart. I think I'm really smart. I might have tried some of this stuff, but don't do it. Okay, so then how do we get better? And I'm almost done, I promise. So I think we need better aggregation of data from longevity clinics that are doing this. I think that's the only way we really start to figure out what works and what doesn't work in this world. Because right now, everybody's trying different stuff, but we never actually get the data to see what the outcomes are at any sort of large scale level. So I think that could help. Really, I think, though, we want the much larger longitudinal, obviously multi-omics as part of that, integrated with the AI tools to kind of get us to the next level of predictive biomarkers that can be used in this sort of an approach. So I've talked about AI just in passing a lot. Again, I don't have time to really get into the details of how I'm thinking about this. I do believe that there are a couple of places where AI is going to be really powerful. The improvement in the signatures, so actionable personal health indicators. And then we, like a lot of people, are really thinking about, can we get to the point where we can use individual healthspan agents to interact with your own data in a meaningful way 24/7. We will get there. There's gonna be some bumps along the way, but that's definitely coming, and that's really exciting. And then I think we need discovery science. I think this is what we're really missing in the field right now, is to get us to that next level. What don't we know? And there's a couple of projects I'm involved in. One is called the Dog Aging Project in companion dogs, so different animal models. Another is Aura Biomedical. You might have heard of the Million Molecule Challenge. So the idea there is high throughput longevity drug discovery. Why do we need that? So today we're at medicine 2.5, maybe 2.25, trying to get to medicine 3.0, where 50% of the population has chronic disease in their 40s. Medicine 3.0, when we're successful, will get us out to where about 50% of the population avoids chronic disease, hopefully into their 70s. I don't think it's going to get us beyond that, though. So I think we really want to be looking towards medicine 5.0, and I think we need these new approaches to kind of shift the survival curve out and hopefully the health span curve at the same time. I don't think we have the tools today. I don't think we know enough about the biology of aging today to do this. That's where things like aura, new discovery, large-scale longitudinal population studies hopefully can help us achieve that. So I'm sorry I went over, but that's the last thing. I'll finish up. If you like this, there's plenty more where that came from. We've got a podcast called the Optispan podcast on YouTube. Check it out if you're interested. Thank you for your attention.